Hi, today we're going to be talking about some really serious topics, particularly for women and the men who love and like them, because we're going to be talking about breast problems, and we're going to be talking about oncology and cancer, which is very similar for those who don't know that. And we're going to be talking with a very prestigious doctor who's here to join us today, Dr. Christina O'Donohue, and I want to introduce you to her. Thank you for joining us.
Thank you so much for having me, Karen.
And you came from Rush Presbyterian St. Luke's, right?
I did. I came from Rush Hospital.
Right down the street from where I went to school at Mount Sinai, right. And we also have Gloria Holland, who's here as our consumer advocate, asking the questions that you might want to ask from your living room. So, of course, I'm going to start with you, Dr. O'Donohue. First of all, I just asked you, and I'm going to ask you again so people know, why did you become a doctor? What interested you in that?
So many different reasons. Initially, to become a doctor, I really do enjoy taking care of people, and you just are in this very unique intersection of somebody's life. You are taking care of them, and you are in, for me in the cancer world, you're in a very scary place in somebody's life. And so I enjoyed that human connection aspect to it, but then also the science of medicine is very intriguing. And I think from an intellectual and a research perspective, I was also very much interested in that aspect of medicine. My grandmother passed away when I was young, and she was, I was very close with her. And I think that's what initially put the seed in my mind to think about medicine. And then going forward, I came to become a surgical oncologist.
But you thought your first leg might be pediatrics?
I went to, initially I thought I would be a pediatrician. I was very interested in advocacy and health policy, actually. And I went to medical school and then did my surgery rotation, which is what medical students will rotate on different rotations in the hospital. And from day one, you literally can save a life in an instant in surgery. I was doing trauma surgery. And I thought it was so exciting and really never pictured myself being a surgeon, but then I went through all the rest of my rotations and nothing seemed to suit me quite the same way. And then I thought I would be a trauma surgeon, and then once I was in my surgical residency, I realized that surgical oncology was the right fit for me.
That's why I like the emergency room, because you could make a difference in a minute too.
Absolutely.
Yeah.
And it's super impactful. People never imagined that they would be in the emergency room that day, and there's certainly tragedies that we see in trauma, and so to both in a surgical way help somebody, but sometimes in an emotional way to help them too. It's a unique position, both nurses and doctors and everybody who's in an ER.
So we wanted to talk specifically today about one thing, about, you know, when a woman is given a diagnosis of cancer, breast cancer specifically, I would want to go for the least possible surgery or the least possible thing if it were me. And most of the nurses I know feel the same way. So that leads to a lumpectomy often, right?
Correct.
Now, can you talk about that?
Sure. So I think it's interesting that to your point that you said you would immediately think of a lumpectomy, and your nursing friends would too, because what I tell patients is I may have 10 patients that want 10 different things. And I think health professionals often may think about certain aspects of their health care. And some people may hear the diagnosis of breast cancer and become very fearful of that. And the real answer is that we have many treatments for breast cancer. And the two main options are a lumpectomy or a mastectomy when you're diagnosed with breast cancer. A lumpectomy is taking a portion of the breast and preserving the rest of your breast, the portion of the breast with the cancer. And a mastectomy is removing the entire breast, and that can be done with or without reconstruction. What many women don't know is that the survival, so how long you live, is equal between a lumpectomy and a mastectomy. The only difference is the recurrence if the cancer comes back, but with radiation, the two techniques become almost equivalent.
And what about chemotherapy? Do you use that a lot or not?
It depends on the tumor biology. So some women we meet, and through screening and mammography, and now we do things like ultrasounds to try to find breast cancers as early as possible. The earlier we find a breast cancer, the less likely a patient will need chemotherapy if it's an early or low-grade breast cancer. So it depends on the size of the tumor and how aggressive the tumor is, and if the tumor has gone to, for instance, the lymph nodes. And those are the factors that determine whether a patient will have
Are you
chemotherapy.
finding them in younger women now than you used to find breast cancer?
No, young women have breast cancer, certainly. We've had even women in their late teens, unfortunately, who've been diagnosed, but I don't know that there's been any data that there's a much younger shift in younger women. But yes, women from, unfortunately, their late teens to their end of their life can have breast cancer.
And men can have it too.
Men can have
You don't
it.
think of that, but they can.
That's right. Actually, I don't know fully, but I heard Beyonce's father was just diagnosed with breast cancer. And so I think men are realizing when they hear these things that something they never thought would happen to them can. It's a very rare, but it is more common in families that have breast cancer and that have the BRCA gene mutation or the BRCA mutation. Men with the BRCA mutation have a much higher risk of having breast cancer in particular, but it can happen without having any genetics as well.
Well, you know, we as women are taught at a fairly early age, check your breasts, you know, do our mammography and all of this, but are the men, do they know to do this? Are they aware of this? I mean, is there still a stigma attached to that?
Yes, so certainly women often are more astute to their own body, and we know that women actually go to the doctor more and are better about screening and all of that. So I think for men to be aware that breast cancer can happen to them. But in general, all cancer screenings, prostate cancer is the most common cancer, colon cancer, getting colonoscopies. I do also melanoma, making sure that you get your skin checks with a dermatologist. I think that all of those things are important for men to be aware of their body as well as women. You know, I often even have women in the health who are health professionals who sometimes
The worst.
don't follow their own
worst,
advice.
yes.
So I think it's important for us all to be aware of our bodies, and if something is, what I always say with cancer is, if something is new and changing, that's something you should check out with your doctor.
You know, Christina, when you're first given a diagnosis of that, you're, I'm sure, pretty overwhelmed. You don't know where to turn. You've touched on a lot of things. Are there questions that some women should be asking maybe that they don't when they're given such a diagnosis in order to make an assessment? Which way should I go? What are other factors I should consider?
Absolutely. It depends how a woman is diagnosed as well. If she palpates something or she finds something through screening. So if a woman finds something through screening, oftentimes the steps are laid forward. But it's important to make sure that your team is comfortable in treating breast cancer or whatever cancer you have specifically. So oftentimes, there are surgeons who may do some breast surgery, but that's not just their specialty. They're not fellowship trained, as well as medical oncologists to make sure that they're comfortable with breast cancer. And so it's always women should feel able to advocate for themselves. I think that's often the challenge, is that a woman is told she has a diagnosis, and sometimes women just don't want to go against what they're being advised to go to this doctor or that doctor, or what the next step is. But I believe to ask family and friends. Oftentimes, unfortunately, breast cancer is is a very common breast cancer. Excuse me. Let me redo that.
Yeah.
I'm sorry. Unfortunately, breast cancer is a very common cancer among women. 1 out of 8 women will have breast cancer. And so oftentimes a woman may know somebody else. And so reaching out to a family and friend, seeing who's treated them, and making sure that they're comfortable with the healthcare team that has been recommended, or seeking a second opinion.
I was going to say, don't be afraid to seek a second opinion, or make sure you have a doctor that you're really comfortable with or you think is best suited for you.
Absolutely.
Because that's an important thing, to feel like he's got or she has your best interests.
Well,
at
for
heart
instance,
always.
what's your background?
So I am a surgical oncologist, and what that means is that I went to medical school, and then after medical
Where?
school at University of Illinois in Chicago, and then I did 7 years of a general surgery residency, and then after that 2 to 3 years of a surgical oncology fellowship.
All in Illinois, or
No,
where else did you go?
I also
It's a trick question. I know you didn't.
So I did my residency also at University of Illinois. I did my research at University of California, San Francisco. I did a master's in public health at Harvard in Boston. And then I did my surgical oncology fellowship at Moffitt Cancer Center in Florida. And so I'm a surgical oncologist. There are also many breast surgeons who did a breast fellowship. So they completed a general surgery residency and then a breast residency. So both of those specialty cancer trainings enable us to, that's the surgery that we do most commonly or very frequently. And so we are very much up to date on the literature, making sure we're giving the appropriate treatments, and then also on technology and what we use in our operating room.
When would you suggest interventional radiology versus surgery?
So for breast cancer, it depends on the stage. So if it's progressed out of the breast, then the discussion changes. But if the cancer is in the breast, then surgery is the only proven treatment that is currently within guidelines. So there are some trials of doing other things, but currently for breast cancer, if it's just in the breast, the first known curative step is surgery.
And so when you do the lumpectomy, I mean, could I say to you, for instance, I want the least type of surgery, but I don't want just a lumpectomy. I want you to resect a quarter of the breast or something.
It depends on, we say, the breast to tumor ratio. So as you can imagine, if a woman has an A cup breast and she wants a quarter of the breast removed, that's one thing. Actually, a great thing for women who are older, who maybe have what we call ptosis, or sagging breasts in other words, and have larger breasts. When you have a diagnosis of breast cancer, the one benefit is that you can have reconstruction that's completely paid for by health insurance. And so both breasts
I was going to say,
can
but only
have-
one? Or
No, both breasts
would
can
be-
have whatever different things that you would like. So one option for women who've had larger breasts is they can have a breast lift and a reduction. And
So now, do
it's
you do
part of it.
implants?
You can do implants too, but so it depends on the size of the tumor and what a woman wants. But when you said, can you remove a quarter of the breast? Sure. If a woman has a larger breast, we can remove a quarter, but generally we want to do the same with the other breast.
But it's my understanding that in that case it would be a 2-stage process. Is that correct?
Not
would
always.
would you get, I mean, the removal
what I was
of
gonna say,
whatever
you could
was
do everything
needed,
at once,
or do you
yeah.
do it all at once?
Most of the time we do it all at once. The one sort of caveat with that is, we were talking about a lumpectomy, is that you want to make sure that you have negative margins. And so oftentimes we use certain technologies in the operating room that it can never ensure it to 100%, but generally our positive margins are around 5%, which is better than the national average. And so depending on the particular tumor, we excise it, and then we have techniques. We can look in the operating room at the part of the breast that we take out.
Like frozen sections, or is that old?
No, frozen sections are still used,
they?
but breast cancer is not good frozen.
No.
So as I said, I do other types
Yeah.
of cancer. Some of them are better than others, looking intraoperatively, but breast tissue, unfortunately, the way it freezes, it's not a good
not a good one.
evaluator. So we use intraoperative mammography. We use intraoperative 3D tomography to look at the breast specimen and see if we can see the cancer. Oftentimes we have all of the time we have a clip that's with it, and to see where that is in the part of the breast we take out, and then we can do the reconstruction most of the time.
Could you explain, since I'm a layperson, explain to me what you mean by the tomography, what that shows you? Is it like thermography? Is it heat coming off of the tumor that shows you, yes, indeed, I got it all? Or how does that help you?
There are multiple different trials going on in technologies, but what we use and what is often commonly used is intraoperative mammography. So we take a portion of the breast in a lumpectomy, and in that tissue is the cancer, the clip that was placed, and a marker that we need to use to find the cancer. So oftentimes when women have a mammogram and they're diagnosed with a cancer, they have a tiny clip that's about the size of a period on a piece of paper that's in their breast. I can't see that clip with my own naked eye. Hopefully most of the time women are diagnosed with an early breast cancer, so I can't feel that cancer either. So I have to use another guide to find in the breast where that tumor is, not my naked eye, or most of the time you can't feel it. And so we are estimating with multiple different ways where that tumor is in the breast. So once we take out the tumor, then we're able to put it into what's a 3D tomography machine that's in the operating room, and actually look at the mammogram of the breast tissue that we excised. And that tells us, do we have the clip? Do we have these calcifications that we might be looking at? Do we have the area that we're aiming for? And then it can also tell us, yes, we have it, but it's really close to one edge. And so then we might take an additional edge.
I was going to say, doesn't it make you want to just keep taking more so that you can be sure?
You're
you
right.
know? Yeah.
There's a balance, though,
Yeah.
because we want for a woman to have a good cosmetic outcome as well. And so we want to have a lumpectomy that's curative, but then also that cosmetically ultimately is a good surgery as well. So that's why taking additional pieces of the breast and taking too much of the breast isn't ideal either.
It's a fine line.
How many times do cysts in the breast turn into cancer?
Regular breast cyst, very
Not-
rarely.
right.
So some women, unfortunately, just have fibrocystic breasts, and they're often followed sometimes more carefully. But plain cyst that doesn't have any other suspicious findings.
Do they ever
very, very
absorb
rarely.
like ovarian cysts do? And
Yes,
just
sometimes as
disappear
women get older, they might have less cystic breasts.
because the hormones are changing?
Yes, that's correct. So if a woman has a new breast cyst and she's older, we'll think about it differently than if she was younger.
Okay. I think I read somewhere in the literature that if you have a lumpectomy, that there's a 20% chance that you might have to go in at some point for a follow-up surgery. In other words, maybe you didn't get it all with the margin, error there. So is there any way to kind of cut that down or avoid that, or any things on the horizon to make that better?
Sure. So the re-excision rate for lumpectomy, meaning you have a diagnosis of a breast cancer, you elect to have the lumpectomy, part of your breast being taken out. We talk about the risk of having a positive margin, meaning we take out a piece of the breast and there's still some cancer on the edge. Nationally is about 20%. At Rush, our numbers actually are closer to 5%. Different ways that we've been able to bring that number down is this intraoperative 3D tomography. We take the portion of breast tissue that we've taken out, we look at it while we're operating, and we determine if we have to take additional margins. And that's helped bring our number down. Oftentimes, additional margins can be taken, but to your point, you don't want to take too much either because it's defeating the point of the lumpectomy. So taking the right breast tissue if needed is important.
If someone should be in that unfortunate case of having to go back and have a follow-up surgery, is there a different success ratio? Is there a different specialist? In other words, are the questions different facing another surgery?
That's an excellent question. So another point I should have brought up is that it's thought that breast surgeons who are fellowship trained have a lower number than the 20%. At some centers, it can be as high as 30%. So surgeon to surgeon and facility to facility can matter as far as what those re-excision numbers are. So those are important questions to also ask. And then most of the time, we can know that the area was very small that was positive, and then we can just take a smaller margin. But in rare circumstances, do women have additional disease that wasn't well seen on imaging? And so that's a thoughtful conversation to have as well, that though a lumpectomy is, the survival is the same in the standard case and the recurrence is almost the same when you use radiation. Sometimes if we can't see everything on imaging before surgery and under the microscope we're seeing more cancer, very, very rarely will women then need to proceed with a mastectomy. But that is a rare circumstance. So if there are positive margins, it's important to ask how large was the positive margin? Were there multiple sites of positive margin, or was it just the tumor was there and it just looks like a small microscopic
Does
focus?
this require a hospitalization or not?
No. Lumpectomies are done outpatient. So that's a great
So is it an
option.
outpatient clinic or in your office, or?
It's in an operating room or a surgery center, but it can be done all on the same day. Yeah.
So what do you think is, it seems like a lot of women are living a long time after breast surgery now, where
Yes.
that didn't used to be true years ago. What do you think is the big difference?
Chemotherapy.
Yeah.
I wish as a surgeon I could say we were responsible for that, but chemotherapy and the administration sometimes before surgery to make the tumor smaller and for us to be able to see a response, and then oftentimes after surgery, as well as oftentimes women, if they have a hormone positive breast cancer, there's different types of breast cancers, will have to take a pill. There's different kinds of pills, but those pills also regulate the hormones, and the combination of...
There's no way you can give chemotherapy locally, though, for something like that. It would almost seem like in a breast, because it is a little distant, that if you didn't have lymph node problem, that you could give some kind of chemotherapy locally.
That's what radiation is. And
Yeah.
radiation, it's not chemotherapy, but to your point of thinking,
locally.
to not make it come back, to treat it in that area.
To not affect the whole body.
To not affect the whole body. That's what radiation is. What we say is radiation changes the DNA of the cells around where that cancer was and sort of cleans up the rest of the breast tissue. And that's why it's different than chemotherapy. The benefit of chemotherapy actually is that if there's any cells that have escaped,
yeah.
then chemotherapy treats the whole body.
Do you ever use like bagging of taking tumors out?
Like
They
yeah.
say in some abdominal surgeries now they're doing that, where they put the bag around it to prevent
Not so
cells
much
from
in
escaping.
breast, because we are just in that cavity, but I do intra-abdominal surgeries, and we do use, especially with minimally invasive, if we're doing laparoscopic or robotic, we often will put it in a bag. But for breast, it's all in that tissue cavity, so it's not exposing it through the whole breast.
So you're saying, though, pretty much that you have to use the two-prong, the radiology,
Radiation,
I mean, and the chemo to follow up to make sure everything is gone.
It depends. So this is where breast can get very complicated. And I tell women that breast cancer is almost an umbrella term, and that there are so many different types of breast cancer that to talk with your friend who's perhaps had breast cancer as well, there are so many nuances to the care that not everyone needs chemotherapy, fortunately. Not everyone needs the pill. And actually, not even everyone needs radiation. If you're over 70 years old and you have a very favorable tumor, sometimes we can forego radiation even. But that's where personalized medicine is really moving forward in all areas of cancer care, and that's where some of these nuances are to know the tumor type that you have, the tumor characteristics, and if chemotherapy and radiation are likely to benefit or not. But most women who have a lumpectomy will have radiation.
So we know who to call now.
And lots of questions. If you
Yeah.
get this diagnosis, lots and lots of
No,
questions.
I don't think
are in
it's so
order.
important that you ask questions, is that you know that your doctor knows the answers to the questions. Forget
And to have
asking the
confidence,
questions. Let your
that's
doctor
true.
worry about it. Get the right doctor, and then
Right.
let the doctor worry about
Well,
it.
that's very sweet. I do recommend for women to write down their questions, or all patients, because we all
You do
can be in the
forget, right.
doctor's office, and even health professionals can forget their own questions. So to write it down, I think, is always very good. But
Okay,
yeah.
we only have a few minutes left, so what would you like people to know that we may not have asked you?
Sure. So I think screening and prevention are absolutely important. So for women to know their own family history, if they have relatives that have had either breast cancer, sometimes prostate cancer, melanoma cancer, pancreatic cancers, certain cancers can run in families. So to get tested if any of these cancers run in your families, and then to start screening. For women that are not at high risk, screening at 40 years old is very important. And then when you continue to screen, to make sure that you are at a good facility that's doing your mammograms. Not everyone may ask questions if the radiologists are a breast radiologist that's reading these mammograms. And that theme continues. So if there is a diagnosis, to make sure you're with a good team that are breast specialists. So at many centers, there will be multidisciplinary tumor board. So if a woman is diagnosed with a breast cancer, multiple different kinds of doctors, the oncologists, the radiologists, the surgeons, all come around on a table, and literally we look at the films of each woman, and we'll discuss what the right treatment is. Because as medicine and as the treatment of breast cancer improves, then it makes it even more diverse for each woman of what the right treatment is, and to make sure that you have the specialists that know what's available. And so those are the things that I think are
It's
are
great
very
information.
important.
It
Now,
is.
tell them where they can reach you.
So I'm at Rush University. You can look us up online at Rush. If you put in Rush Breast Cancer, you will find any of us, or Rush Surgical Oncology. And should I give a phone number?
Sure, go ahead.
312-942-5000 is the number to the general Rush number. And you
And
can
you're Dr.
certainly ask.
Christina O'Donohue, right?
Christina O'Donohue.
So everybody knows who you are.
Thank
Well,
you
thank
so
you so
much.
much for joining us. I know you have a very busy schedule, and I know it's rough on surgeons to get them here. So thank you.
thank you so much,
very
both of
And
you.
it's a lot of peace of mind knowing if
Yeah.
we're approached with this problem, we know
Where to go.
where to go.
Right.
Absolutely, and that there's treatments for sure.
Right. Thank you.
so
Thank
much.
you so much. And thank you for joining us. We'll see you next time. I'm Karen Gibson. Thank you.